Hello friends, welcome back to my channel Medicine Hub 101. Today we'll talk about the management of type 2 diabetes. Okay, management of the type 2 diabetes mellitus. In the previous bit of the diabetes, I have already explained what type of the causes we will get over here in terms of the Let's repeat once again. If we say in terms of the type 1 diabetes mellitus, we'll get what the autoantibodies against the pancreatic beta cells. So we'll get over here what the destructions of the pancreatic beta cells. So whenever the pancreatic beta cells they will be destroyed, definitely the insulin production that will be severely less. In case of the type 2 diabetes mellitus, I already said what type of the problem we'll face over here. That the insulin resistance will get over here. The insulin resistance, that means the insulin productions that may be good, but the problem will be where within the receptors of the insulin. Okay, so here we'll get the insulin resistance. So let's write it over here. We'll get the insulin resistance. That means if the insulin is produced good, but the problem will be where at the level of the insulin receptors. Okay. So here we get the insulin receptors. They will be not able to work properly. Okay. Now see, whatever the problem we'll see over here, we can get the problems, or we can see in terms of the etiologies, in terms of the genetical problem. So here we'll get the polygenetic problem. Whatever the problem I'm going to say within a minute. See, there are certain kinds of the genes that are responsible for producing the two types of the thing. What are they? So one will get the adipokines. Adipokines. And these adipokines, that will be what? That is responsible for developing the weight gain. So here we will get the what? Weight gain. Okay. And there are another kinds of the things that is known as adiponectin. So the adiponectin we see over here. Adiponectin, that is responsible for, this is against the what? Obesity. So you can write it over here. Garden against obesity. And in type 2 diabetes mellitus we will see the activity of the adipokines that will be increased. So we will get toward the weight gain, and the simultaneously we will get toward the activations of the adiponectin that will be under regulation. That means the adiponectin that will be less stimulated, and the adipokines that will be more stimulated. As a result, we will get the weight gain, and along with that we will get what? The whenever they are against the obesity, so definitely what? They will, whenever it is under regulated, so definitely we will get the development of the obesity in type 2 diabetes mellitus. So basically we will get over here in terms of these things, that in terms of the weight gain we will get the fat depositions within the adipose tissue. The fat depositions within the adipose tissue. So for the fat depositions we will get the weight gain over here. And in terms of adiponectin, that I already said, there is the guardian against the obesity. Now whenever we are getting the fat depositions, along with that in type 2 diabetes mellitus, what do we know? There will be the muscle wasting. So muscle wastage you will get over also here. So we will get along with that, there the muscle wastage. Now try to understand from here, when you are talking in terms of the weight gain, in terms of the fat depositions, we are getting what? The muscle wastage. So whenever we will get the muscle wastage, definitely if we say that individuals to work, to work just like a normal individual, then the patients, or we can say the individuals, they will be not able to work that much like a normal individual. So in these cases, whatever the problem we can say, there will be the fatigue. You get the fatigue. Okay. Now this thing is called in a term that is known as asthenia. So in the better word we can say over here, asthenia. Okay. Now see, when you are talking in terms of the management, so whenever you are getting the weight gain, and whenever we are getting the activations of the adiponectin against the obesity. Okay, so how can we just manage these things? So first thing that will come in your mind, that's what the things that we can manage by doing these things. The first things we can just restrict the what? Diet, and the next things we can what? We can just do the exercise over here. So the two types of the things we'll get over here just to manage. The first thing you can write it over here. Initially, when we will diagnose the patients who is diabetic over here in type 2 diabetes mellitus, first things we can talk in terms of the diet restrictions, diet or restriction, and the second thing you can see in terms of the exercise. So when we are talking in terms of the diet restrictions, definitely we are supposed to say the individuals to avoid the carbohydrate. That means the carbohydrate rich food. But yet the individuals they can have the carbohydrate, but the carbohydrate food that are having the low glycemic index. Okay, I'm going in details later. Let's talk about first the exercise. So when you are talking in terms of the exercise, I've already said you these individuals they will not able to work that much. So if I say the individuals to work the for the heavy exercise. So, for example, the individual is saying, "Doctor, should I join in the gym?" That means he is not supposed to do that kind of the gym over here. So, what should he say the patient? The patient is supposed to do the jogging or walking over here. You can write 30 minutes per day. 30 minutes per day. And in a week we need at least 5 times these things. So if we write in terms of the weeks, so 30 multiply 5 minutes per week. So you can write 150 minutes per week the individual is supposed to have the exercise. So basically it will be what the light aerobic exercise, the light aerobic exercise. And whatever the diet restrictions over here, in these things we can write that here we will get the carbohydrate restrictions, basically carbohydrate or restrictions. But the individuals can have the what? The low glycemic index food. That means low, if you write it over here, that the persons or the individuals who are having the diabetes mellitus, they can have the low index yeah, glycemic food. When you are talking in terms of the low index glycemic food, whatever the food will get over here, we'll get the oats. Okay, the persons can have the oats, or the persons can have the bread, or the persons can have multigrain atta, or the persons can have the the white meat, not the red meat. Okay, he can have for example he can have the chicken biryani, little amount, not that much. So we can write it over here the white meat, not the red meat. Red meat is strictly prohibited in these cases. Okay, white meat. Now he should avoid some the trans food, the trans fatty acids. For example, the individual is supposed to go. In this case, if I say the individual thinks to go while within the restaurant, but in the restaurant, what do you know? Definitely the oil that is used. So the oil is used multiple times. So whenever the oil that will be used multiple times, the oil that will be converted into what? Trans fat. So the trans fat is too much dangerous in this case. So the individual should avoid the restaurants over here because of what? Because just to avoid the trans fat over here. Okay. Now why you are saying so in terms of the exercise? See, whenever we are saying the exercise, in these cases, whenever the individual they will do the exercise, in these cases, the GLUT4 receptors, the activity of the GLUT4 receptors that will be increased. So definitely we can say this. Along with that, we can also say the insulin production that may be also increased. So along with that, the GLUT4 mediated glucose uptake within the cells that will be also increased. Now, for example, we have said these patients or the individuals to do these things. After that, yet we are getting the blood sugar that is not coming into the control. The blood sugar is not coming in the normal range. For example, yet we are getting the HbA1c value more than 7, for example. So in this case, what should we start over here? In this case, at first we should start oral hypoglycemic agents. So we have the individual have done all these things, but yet we are not getting the control blood sugar level at the time you are supposed to say individuals to have the oral hypoglycemic agents. Now we'll talk about those things. Okay, let's talk about those things. So after doing this, whenever the individuals is not able to control the blood sugar level at that time, you can start the oral hypoglycemic agents. So in this cases, let's write it over here. We will write what the oral hypoglycemic agent. So whenever we will get the newly diagnosed type 2 diabetes mellitus individuals, we should start the oral hypoglycemic agents. So in these cases, the first drug that should be used, that is what? I hope all of you know it. That is known as what? Metformin or bugonide. So the first drugs we can use over here, the bugonide or the, you know, right over the metformin. Now see, what are the thing we need to know about this drug? The mechanism of the actions of this drug. This drug inhibit the hepatic neoglucogenesis. This drug inhibit the hepatic neoglucogenesis. So let's show over here. Okay, let's use this color only. So this drug, the mechanism of actions for this drug, they inhibit the hepatic gluconeogenesis. Whenever the hepatic gluconeogenesis is stopped, definitely you are supposed to know that the HbA1c level that should drop. Okay, but if we see, for example, if we get, whenever we are diagnosing the patients, after diagnosis, if we get the patient is having the HbA1c level, if we get the HbA1c level more than 10%, at the time we should say the patient should go for the insulin injections. The patient should go what? For the insulin injections over here. So insulin should be injected in these cases. Okay. Now in these cases we will get, you know, the bugonide, they are having the capacity to decrease the HbA1c level by 2%. So the HbA1c level that been decreased by using the what of metformin by 2% over here. Okay, this is the mechanism of actions for them. But whatever the problem we will see in the bugonide or the metformin, see if any individuals who are having, try to understand any individuals who is having the renal problems. For example, basically what do you know? This drug that should be excreted through the urine. So if we say that if we see the individual is having the renal problem, for we are using these drugs, for that the renal system is compromised. In these cases, you are not supposed to use this drug. For example, why? If we get the renal problem over here, and if we use the bugonide, that will develop the lactic acidosis. It's one of the most important side effects you can see over here. Okay. Now, how can we just measure? For that thing, we have to do the test. For that thing, before starting the bugonide, you can just do the test. If we get the estimated GFR level, if we get less than 30 to 45 ml per minute, that means the kidney is compromised. So we are not supposed to use this drug. Or along with that, if we get the serum creatinine level, if we get more than 1.5%, then we should avoid this drug. Okay. So at that time, we have to use the different kinds of the drugs. But if we say in this in the whole life, if we say in a nutshell, the drug of choice, if the renal compromisation is not over there, then the drug of choice in type 2 diabetes mellitus, that should be the metformin. Okay, it should be the drug of choice over here. Okay. Now what about the dose? Okay. What about the dose? Let's use this one. The dose we can use over here, the maximum dose for the metformin, we can use the dose 500 milligram, we can use the 800 milligram, or we can use 1 gram. But the maximum dose we can have over here, that is around 2.5 gram per day, not more than that. And this dose, that is dependent on the fat, depositions of the fat, or you can say the weight of the individuals over here. Now, if we are not able, the individual, for example, the individual is having the renal problem, I have already said we are supposed to avoid the metformin. So what kind of the drugs we can use over here? Let's talk about them first. Okay. So let's talk about them first. Now see, whenever this drug is getting excreted through the urinary systems, then we can use some drugs. For example, the drug of choice in type 2 diabetes mellitus with renal compromisations or the renal problem, whatever the drug we can use. So we can use any drugs. Okay, first we can just inject the insulin. The first thing, we can inject the insulin. The second thing, we can use some drugs that will be metabolized by liver. So whenever it will be metabolized by liver, definitely there will be no problem with the in the kidney. So in the excretions. So any kind of the drug we can use metabolized by liver. Now, whatever the drug we can use over here, we can use the linagliptin, we can use linagliptin, okay. We can use glipin. Okay, let's use the different color for it. We can use the glipizide. We can use the glipizide, or we can use, tolbutamide. So see, I am repeating once again, tolbutamide. Now, whenever we are getting the individual is having the renal problem, at that time you can either inject the insulins or you can give the drugs that will be metabolized by liver. Here you can use the linagliptin, we can use the glipizide, or you can use the tolbutamide over here. Okay. Now, whatever the problem we will see over here, let's talk about those things. Okay. See, when we are talking in terms of the HbA1c control, okay, see, let's use the definitions for it. When we are talking in terms of the complications of the diabetes mellitus, let's write it over here. If we see the microvascular complications, in these cases, the HbA1c value should be controlled. It should be controlled. And if we see the macrovascular complications, then in these cases we'll see the BP, the blood pressures that should be within the normal range. Okay. Now we'll talk about the different kinds of the drugs, other drugs. For example, we have used the metformin. After using the metformin, we are not getting the the desirable result. For example, yet the blood sugar control, that is not within the normal range. So whatever the drugs we can use after that, after the metformin, whatever the drugs we can use over here. Let's talk about them. So after the metformin, we can use the group of the drugs that is known as sulfonylurea. Okay. So we can use the sulfonylurea. Why we will use sulfonylurea? Try to understand. It is having also the capacity to reduce the HbA1c level by 2% over here. But whenever using the sulfonylurea, at the time you have to continue also the metformin. You have to also continue the metformin over here. Okay. Now, whatever the drugs will get under the sulfonylurea groups, will get glipizide. We'll get the glipizide over here. We'll get glyburide. Or we can get the glycoside. But the problem in this case is that whenever you're using this drug, the one side effect is over here that can cause the hypoglycemia. So we'll get the problem where at the level of hypoglycemic. Why we get the hypoglycemia? You have to understand also over here. Okay. So in these cases we'll get what I have said, we'll get hypoglycemic conditions. So when you are talking in terms of the hypoglycemic conditions, because the mechanisms of the actions in these cases of these drugs they will increase the productions of the insulin. Along with that, they will also increase the activations of insulin receptors. So whenever we have, for example, any individual who has taken their drugs, after that he is just feeling the hypoglycemia. Why? After eating their drugs, the instant within the 15 to 20 minutes, so whatever the blood glucose is within the blood, for the increasing of the insulin and the insulin resistance, the insulin and the insulin receptors over here, for their actions, the glucose that will be taken within the cell. As a result, the individual, they will feel what? They will feel hungry over here. So they will feel hypoglycemic. That's why in these cases, the main important thing, just to avoid this thing, the meals that should be regulated properly. Okay. So we'll write it over here that meals should be on time. For example, any individual who has taken the meal, after that he some urgent work and he has forgot to eat. He has forgot to eat the things what he is supposed to eat. After that he has taken the medications. It's good, but he has forgot to eat the food. At that time what? After taking the medications, within 15 to 20 minutes, we'll see the individual will feel what the hypoglycemic things. In these cases the meat should be on time over here, just to avoid this type of the thing. Okay. Now see, in these cases also we'll get what the HbA1c level, HbA1c level, that should be also decreased by 2%. That should be also decreased by 2%. And we have to continue along with that. I have already said you have to continue the metformin. So sulfonylurea plus metformin you have to use over here. Now the third group of the drugs, whatever the drugs we can use over here. Okay, let's talk about them first. Then I'll go back to the details. Okay, I'll talk about those things later. First, know this first. Okay, for example, is the pattern. In the subsequent parts, we'll talk about the details. Otherwise, the videos that will be longer, so it will take too much time. So, see you in the next video. If you don't understand any points regarding the management of the type 2 diabetes mellitus, please let me know in these cases. Okay, see you in the next video soon, and thanks for watching.